Hello everyone and welcome to our module on diabetes complications. In patients who have diabetes mellitus, chronic hyperglycemia over time leads to complications, and this is what makes diabetes mellitus such a serious and potentially life-threatening condition. So patients with diabetes mellitus can develop vascular disease and kidney disease as a complication of diabetes. They can also develop neuropathy and ocular disease, including blindness. And so in this video, we'll talk about these complications of diabetes mellitus, and we'll also talk about the things you can do to prevent them from occurring. Diabetic macroangiopathy refers to accelerated atherosclerosis, which occurs in patients with diabetes, and it predominantly affects the large blood vessels. That's why it's called macroangiopathy. So patients who have diabetes can develop coronary artery disease. This is the most common cause of death among patients who have diabetes. Patients with diabetes can also develop stroke and TIA and also peripheral vascular disease. And all of these things are manifestations of large vessel atherosclerosis, which is accelerated in patients who have diabetes. Because of the risk of accelerated atherosclerosis, the American Diabetes Association recommends a screening lipid panel in patients with diabetes at the time of their diagnosis and then at least every 5 years thereafter. Also, because of the increased risk of vascular disease in diabetes, statin therapy is recommended in some cases. The guidelines for this come from the U.S. Preventative Services Task Force. They recommend a statin in all patients who have diabetes and age greater than or equal to 40 and a 10-year estimated risk of cardiovascular events that is greater than 10%. And there are a number of online calculators you can use where you enter a patient's demographics and other information like blood pressure and cholesterol measurements, and it will tell you the estimated 10-year risk of cardiovascular events. So if a patient meets these criteria here, according to the U.S. Preventative Services Task Force guidelines, they should be placed on a statin regardless of their LDL level. And don't let this fool you in a board question. Even if the LDL level does not appear significantly elevated, if they meet these criteria, they should be placed on a statin. And then you might think, because of the high risk of vascular disease and diabetes, that things like routine EKGs or stress tests or brain imaging might be recommended, but the studies on these things have not shown that they're beneficial, so these things are generally not indicated. Diabetic kidney disease is an example of diabetic microangiopathy, and it has the word micro in the name because it involves small blood vessels like arterioles. In diabetic kidney disease, there's damage to the glomeruli and the arterioles in the kidneys. There are a number of processes that contribute to this, but one of the things that happens is the efferent arteriole becomes glycosylated. This means that glucose molecules attach themselves to the efferent arteriolar structures, and this causes the individual glomeruli to begin filtering more blood, a process known as hyperfiltration, which occurs early on in diabetic kidney disease. Although it might sound like hyperfiltration is a good thing because the kidneys are filtering more blood, it's actually very damaging over time. It eventually leads to basement membrane damage, and then it can lead to sclerosis in the glomeruli and the mesangium, which is the tissue that surrounds the glomeruli. And once sclerosis begins to set in, then the overall glomerular filtration rate begins to fall, and then patients can go on to develop renal failure. Early on in diabetic kidney disease, patients develop albuminuria. Normally, there's very little albumin that finds its way into the urine, but the level of albumin in the urine can go up in early diabetic kidney disease. And we'll talk about this in just a minute because it's useful for screening. Eventually, diabetes can lead to end-stage kidney disease, and patients can require renal replacement therapy like dialysis. Screening for diabetic kidney disease is done through an annual urine test called an albumin to creatinine ratio. In this test, you send a urine sample to the lab, and they determine the albumin concentration and the creatinine concentration, and then they determine the albumin to creatinine ratio. And this ratio can be correlated to a value for 24-hour urinary excretion of albumin in milligrams per day. And the normal rate of albumin excretion is less than 30 milligrams per day. Any value above 30 milligrams per day indicates the presence of diabetic nephropathy. Once patients have diabetic nephropathy identified by the albumin to creatinine ratio test, they should be placed on either an ACE inhibitor or an angiotensin receptor blocker. These drugs are indicated for all patients with diabetes who have albuminuria, meaning an excretion of albumin more than 30 milligrams per day, even if their blood pressure is not elevated. And don't let this fool you on a board question. The patient may have normal blood pressure, but if they have albuminuria, then they need to be on an ACE inhibitor or an ARB. These classes of drugs have been shown to reduce the progression of diabetic kidney disease to end-stage renal disease and dialysis. They've also been shown to slow the progression of nephropathy overall. And then besides treating patients who have albuminuria with ACE inhibitors and ARBs, another thing we do to prevent diabetic kidney disease is treating hypertension. And the goal for hypertension in patients with diabetes is less than 130/80. And this goal is identified in part in order to reduce the risk of development of diabetic kidney disease. Next, let's talk about diabetic neuropathy, which refers to nerve damage associated with diabetes. And the most common form is diabetic peripheral neuropathy, involving the peripheral nerves that go to the arms and the legs. This is sometimes referred to as a distal symmetric polyneuropathy, and it gets this name because it affects distal structures, like the nerves to the hands and the feet, and it's symmetric, involving nerves on both sides of the body. Diabetic peripheral neuropathy classically causes what's known as stocking glove sensory loss. This means loss of sensation in the areas that would be covered by stockings or gloves, like the hands or the feet. The sensory loss is usually progressive. It begins distally, for example, in the feet, and then spreads proximally over time, eventually involving the entire leg. And although peripheral neuropathy is usually a sensory neuropathy with loss of sensation, in severe cases it can lead to motor weakness. If you look at this table shown on this slide, diabetic peripheral neuropathy affects large myelinated and small myelinated fibers. The large myelinated nerve fibers are responsible for proprioception and pressure sensation. So when there's neuropathy involving these nerve fibers, patients develop numbness and loss of balance. And so loss of large myelinated nerve fiber function on exam can lead to things like reduced ankle reflexes or poor vibration or proprioception sensation. The small myelinated fibers are responsible for pain, so when there's neuropathy involving these fibers, patients can complain of a burning sensation in the feet or a sensation of electric shocks. And damage to the small fibers is detected on exam by things like loss of pinprick sensation and loss of hot and cold discrimination. A major clinical problem that results from peripheral neuropathy in diabetes is the development of diabetic foot ulcers. These happen because there's a loss of sensation, and this leads to tissue damage in the feet. And then because patients with diabetes have vascular disease, they have impaired healing. And so this can lead to chronic foot ulcers, which can be a source of infection. They're sometimes painless because patients with diabetic neuropathy don't sense the development of a foot ulcer. And because of the possibility of foot ulcers, patients with diabetes are taught that they should check their feet every day for evidence of tissue damage so that it can be treated early. And part of the management of patients with diabetes is an annual foot exam and sensory testing. In addition to inspection of the foot, this involves testing for loss of sensation in the foot. So monofilaments are thin fibers that you can use to test whether or not the patient can sense pressure, and this is often done every year in patients with diabetes. You can also test for their sensation of vibration and pinprick, and you also test the ankle reflexes. And when these tests are abnormal, that indicates the patient is developing peripheral neuropathy, and that means their risk of developing foot ulcers is higher. Peripheral neuropathy in diabetes is generally not reversible, so the goal is to slow progression. Usually patients cannot recover any nerve function that's been lost. And good control of blood glucose has been shown to slow progression of neuropathy, and we'll talk more about this at the end of this video. And then for patients with diabetes who have pain in their feet from neuropathy, like burning pain or stabbing pain, there are a number of classes of drugs that can sometimes be used. This includes SNRIs like duloxetine or venlafaxine. Also, tricyclic antidepressants are commonly used for this indication, especially amitriptyline, but also sometimes desipramine or nortriptyline. And then two anti-epileptic drugs, pregabalin and gabapentin, are also used to treat peripheral neuropathy symptoms. Peripheral neuropathy is the most common form of diabetic neuropathy, but another important form is autonomic neuropathy. This refers to abnormal function of autonomic nerves related to the sympathetic and parasympathetic nervous system, and this can also develop from long-standing diabetes. When autonomic neuropathy involves the genitourinary system, it can lead to bladder dysfunction and erectile dysfunction. If it involves the GI tract, it can lead to gastroparesis. And in the cardiovascular system, autonomic neuropathy can lead to orthostatic hypotension. When patients stand, they're unable to vasoconstrict their arterioles due to neuropathy, so they develop dizziness and sometimes even syncope. Autonomic neuropathy can also lead to silent ischemia. This EKG on the screen shows an ST elevation myocardial infarction, and in some patients with diabetic autonomic neuropathy, they will have no symptoms of chest pain from myocardial ischemia and infarction like what's shown on the screen, and this is called silent ischemia. In these patients, the only evidence of ischemia can be when their ejection fraction falls and they develop heart failure, or if they develop an arrhythmia. And silent ischemia occurs in patients with diabetics when they have autonomic neuropathy involving the innervation to the heart. And then the last group of complications we'll discuss are the various forms of diabetic eye disease. So patients with diabetes are at increased risk for cataracts and glaucoma. They can develop damage to the retina that can lead to blindness. This is called diabetic retinopathy, and they're also at risk for diabetic macular edema. Because of the eye complications of diabetes, patients who have diabetes require annual screening for prevention of eye problems. They should have a dilated fundus examination by a trained specialist, usually an ophthalmologist or an optometrist. Providers have to have special training to detect these complications early and to know how to treat them. Cataracts are an opacification of the lens of the eye, and there's an increased risk of cataracts in patients who have diabetes. The reason for this is that a substance called sorbitol accumulates in the lens of the eye among patients with diabetes. And sorbitol raises the osmolarity of the lens, and this draws fluid into the lens and causes it to become opacified over time. Diabetic retinopathy is damage to the retina, and left untreated, this can cause blindness. It's divided into two types, non-proliferative and proliferative. Non-proliferative retinopathy basically means damage to the vessels and the nerve structures in the retina. So the small blood vessels in the retina can develop microaneurysms or hemorrhages as part of non-proliferative retinopathy. You can also identify exudates in the retina. This is leakage of proteins and lipids. And then another classic manifestation is the presence of cotton wool spots, shown in this image on the slide here. These are caused by small amounts of ischemia causing nerve infarctions in the retina. Less common than non-proliferative retinopathy is proliferative retinopathy. This occurs when there's ischemia in the retina and it leads to new blood vessel growth. This is called neovascularization. This is very damaging to the retina and can lead to blindness. It's treated with laser photocoagulation, which basically eliminates the new blood vessel growth. It's also treated with intraocular injections of anti-VEGF agents. These are agents that stop the growth of new blood vessels. Now that we've talked about the complications of diabetes, let's talk about the benefits of lowering blood glucose among patients who have diabetes. There have been a number of large randomized trials of intensive glycemic control among patients who have diabetes. These studies randomize patients to lower versus higher hemoglobin A1C targets. And from these studies, we've learned the benefits of intensive glycemic control, meaning the benefits of getting the blood glucose level down so that the patient reaches their hemoglobin A1C target. In type 2 diabetes, intensive glycemic control lowers the risk of microvascular complications, mostly retinopathy and nephropathy. Interestingly, the large randomized studies have shown little impact of controlling the blood glucose level on macrovascular complications like myocardial infarction and stroke. This is very high yield to note for your boards. When you control the blood glucose level in patients with type 2 diabetes, there isn't a lot of evidence that you're reducing the risk of myocardial infarction and stroke. Most of the evidence says you're reducing the risk of complications like retinopathy and nephropathy. And then there was one famous study among patients with type 2 diabetes called the ACCORD trial, where one group of patients had a very low hemoglobin A1C target of 6 to 6.5%. And in this group, there was an increased mortality rate related to episodes of hypoglycemia. So in type 2 diabetes, we usually don't target an A1C value this low. The usual target is less than 7%. You don't try to get it down close to 6, and that's because of the findings of the ACCORD trial showing increased mortality. In type 1 diabetes, the studies of intensive glycemic control have shown a lower risk of most complications, microvascular and macrovascular. It's only in type 2 diabetes where the studies have shown that there isn't a benefit of glucose control on macrovascular disease. And that concludes our module on diabetes complications.